Tuberculosis. Tuberculosis is a specific infectious disease caused by Mycobacterium tuberculosis. The disease primarily affects lung and causes pulmonary tuberculosis. It can also affect intestine, meninges, bone, joint, lymph nodes, lymph glands, skin, other tissues of the body. The disease is usually chronic with varying clinical manifestation. The disease also affects animals like cattle. This is known as bovine tuberculosis, which may sometimes be communicated to man. Pulmonary tuberculosis, the most important form of tuberculosis, which affect man, will be considered here. Natural history of tuberculosis. Agent. Mycobacterium tuberculosis is facultative intracellular parasite. It is readily ingested by phagocytes and is resistant to intracellular killing. Of importance to man are the human and bovine strains. The human strains is responsible for the vast majority of cases. The bovine strains affected mainly cattle and other animals. The bovine strains affect mainly cattle and other animals. Regarding virulence, the Indian tubercular bacilli is said to be less virulent than the European bacilli. Source of infections. There are two sources of infections, human and bovine. Human source. The most common source of infection in the human cases whose sputum is positive for tubercular bacilli and who has either received non-treatment or has not been treated fully. An estimated annual average of 10 to 15% contract the infectious from one case of infectious, primarily TB. Such sources can discharge the bacilli in their sputum for years. The tubercular bacilli in a human cases are usually mixed group. Some multiple very rapidly and some slowly. The more rapidly a bacillary strain multiples, the more susceptible it is to the bactericidal action of chemotherapeutic drugs. The slow multipliers are the source of persister or dominant bacilli. They can be remain alive for years without causing harm to the host. But when the conditions are favorable, they may start multiplying again and cause active disease. That is, they are the seed of future relapse. Bovine source. The bovine source of infection is usually infected milk. There is no definite evidence that bovine tuberculosis is a problem in this country because of the parasites of because of the practice of boiling milks before conception. Communicability. Patients are infective as long as they remain untreated. Effective antimicrobial treatment reduces ineffectivity by 90% within 48 hours. Age. Tuberculosis affected all age groups. Hereditary. Tuberculosis is not a hereditary disease. Nutrition. Malnutrition is widely believed to predispose to tuberculosis, but the available evidence on this point is only indirect. Immunity. Man has no inherited immunity against tuberculosis. It acquired as a result of natural infection or BCG vaccine. Past infections with a atypical mycobacteria is also credited with a certain amount of natural acquired immunity. It is now known that both delayed hypersensitivity and acquired resistance to tuberculosis are cell-mediated response. In most cases, the cellular immunity proves adequate to the limit further multiplication and spread to bacilli. Social factors. Tuberculosis is a social disease with a medical aspect. It has been described as a barometer of social welfare. The social factors include many non medical factors such as poor quality of life, poor housing, and overcrowding, population explosion, undernutrition, lack of education, large families, early marriage, lack of awareness of causes of illness. All these factors are interrelated and contribute to the occurrence and spread of tuberculosis. In fact, tuberculosis began to decline in the Western world long before the advent of chemotherapeutic drugs. This has been attributed to improvement in quality of life. Once again, discussed about what is TB. Tuberculosis, the causative factor is Mycobacterium tuberculosis. Group acid fast bacilli. It is an aerobic bacterium. Shape of Mycobacterium tuberculosis is rod shape. Epidemic disease. It is an epidemic disease. Airborne. It is transmitted through droplet nuclei. This is airborne disease. Staining cell Nelson. Location can occur anywhere in the body, example spine, meninges, bone, kidney, intestine. Because of the growth of organisms, only oxygen is needed. In lungs, infection most commonly affected upper lobe, where oxygen concentration is high. Incubation period 2 to 12 weeks. Clinical features of TB: fever, night sweat, productive cough, client show, Braille's respiration or pooping sound, dry cough, weakness, anorexia, chest pain, weight loss, hemoptysis, crackles, increased fremitus. Diagnostic tests are history collection, physical examination, X-ray. X-ray shows upper lobe infiltration. Montague's test. It is an intradermal skin sensitivity test. Site is inner aspect of upper 1/3 of the forearm on the left hand. It is an intradermal skin sensitivity test. Site is inner surface of upper arm 1/3 of the forearm of the left hand. Using 26 gauge needle, amount 0.1 ml. In duration after 48 to 72 hours. If redness or itching occur, that means allergy with PPD. Not positive Montague test. Palpable raised area denoting positive 5 mm or more. HIV person with a recent contact with the acute TB patient or organ transplanted. X-ray finding shows 10 mm or more. Drug absent. CKD, DM, low blood body weight, child less than 4, healthcare workers. Reason for false positive test means it expected those who are taken BCG and after TB attacks, Montague's tests remain positive for lifelong. Reason for the false positive test means expected those who are taken BCG vaccine and after TB attack, Montague's tests remain positive for a lifelong. Sputum acid fast bacilli. It is a confirmatory test of TB. What is preliminary test of TB? Preliminary test or sensitivity test, that is Montague test. But confirmatory test, it means sputum acid fast bacilli. Sputum test. Sputum culture is one of the most confirmative test of TB. Prevention. Isolate the patient. we will provide a negative pressure room. Always close the door and windows and use N95 mask whenever suspecting as the patient and its confirmation situation. Both patient and health workers provide BCG. BCG normally used ID intradermally. Treatment 99 dots RNTCP 2017. Initial phase for FDC, that means fixed dose combination. RIEP. RIEP means R rifampicin, isoniazid, E for ethambutol, P for pyroxenamide. Right. R for rifampicin, I stand for isoniazid, E stand for ethambutol, P stands for pyroxenamide. This is initial phase of TB DOTS medication. Continue phrase 3 FCDRIE. That means RIE means rifampicin, isoniazid, ethambutol. This is continuous phase. We will give rifampicin, isoniazid, ethambutol, RIE. Diet are high calories, protein, iron and vitamin rich diet. Vitamin C rich diet. Nursing care reassure the client that after 2 to 3 weeks of medication therapy, it is unlikely that the client infect anyone. Daily dose. First line drugs are streptomycin, rifampicin, ethambutol, pyroxenamide, isoniazid. These are the first line drugs. Name of the drugs. Streptomycin. Nursing intervention. It is the form of injection. Streptomycin we get, it is an injection form. It is an aminoglycoside antibiotic. It is contraindicated in pregnancy. Side effects are nephrotoxic, ototoxicity. Streptomycin. First drug, streptomycin. The nursing intervention is it is the form of injection. It is an aminoglycoside antibiotic. It is contraindicated in pregnancy. Side effects are nephrotoxicity, ototoxicity. Rifampicin. Rifampicin nursing intervention. Instruct the client to take the tablet in early morning with the empty stomach. Urine color become orange on the next day onwards. Hepatic toxic drug. So monitor LFT frequently. Rifampicin. Rifampicin, it is if you give rifampicin to that patient, the most nursing interventions are instruct the client to take the tablet in early morning with empty stomach. Usually urine color become orange on the next day onwards. So tell the patient about the color change of urine because of the usage of this tablet. So next we daily monitor the LFT because it is an hepatotoxic drug. So monitor LFT frequently. Once again I read rifampicin. Rifampicin means it is instruct the client to take the tablet in early morning with the empty stomach. Urine color become orange on next day onwards. Hepatic toxic drugs. So monitor LFT frequently. Isoniazid. More hepatotoxic drugs. Isoniazid is an hepatotoxic drug. It is more severe form, leads to hepatotoxic. So it can cause peripherally neuropathy. So instruct the client to take vitamin B6 food. Isoniazid, it is more hepatotoxic drug. It causes peripheral neuropathy. So instruct the client to take vitamin B6 food. Ethambutol. Ethambutol side effects is optic neuritis, color vision, red-green color blindness. If you take ethambutol, you get some side effect. That means optic neuritis, color vision problems, red-green color blindness may be occurred. So, explain the patient about the side effects of this drug. Pyroxenamide. Pyroxenamide means hepatotoxicity. Instruct the client to take much more water, otherwise gout-like symptoms develop. Pyroxenamide, it is one of another hepatotoxic drug. It instruct the client to take much more water, otherwise gout-like symptoms may be developed. Second line drugs are gentamicin, amikacin, tetracycline. Second line drugs, gentamicin. It is an ototoxic and a nephrotoxic drug. Amikacin is one of the nephrotoxic drugs used in all day. If you use in amikacin, nephrotoxicity is seen in old age time. Tetracycline in less than 12 years can nephrotoxicity and oral syrup can cause tooth stain. So, if you take tetracycline, less than 12 years can nephrotoxicity and oral syrup can cause tooth stain. Tetracycline side effects are visual changes, blurred vision, decreased color perception. Visual changes, blurred vision, decreased color perceptions are seen in tetracycline patient. Nursing diagnosis, impaired gas exchange related. Next nursing diagnosis is ineffective airway clearance. This is the concise form of TB. DOTS. DOTS remains central to the public health approach to tuberculosis control, which is now presented as Stop TB strategy. Stop TB strategy to be classified as DOTS. A country must have officially accepted and adopted the strategy by 2004 and must have implemented the four technical components of DOTS in at least part of the country. DOTS coverage is defined as the percentage of the national population living in area where health services have adopted DOTS. Areas are the lowest administrative or management unit in the country. Township, district, countries, etc. Globally, the DOT strategies has been recognized as the best cost-effective approach to tuberculosis control. The advantages of DOTs are accuracy of TB diagnosis is more than doubled. Treatment success rate is up to 95%. Prevent the spread of tuberculosis infection, thus reducing the incidence and prevalence of TB, improve quality of healthcare and remove stigma associated with TB, prevents failure of treatment and the emergency of MDR TB by ensuring the patient adherence and uninterrupted drug supply, help alleviate poverty by save lives, reducing duration of the illness and preventing spread of infection. Lends credibility to TB control effort. The target of DOTS programs was successfully treatment of cure rate of 85% of the new smear positive cases and detection of 70% of such cases by the year of 2000. Anti-tuberculosis drugs. There are now 12 of 13 drugs active against Mycobacterium tuberculosis, of which 6 are considered to be essential. An anti-tuberculosis drug should be safely the following criteria: highly effective, free from side effects, easy to administer, reasonable, cheap. The currently use of drug may be classified into two groups: bactericidal and bacteriostatic. Bactericidal drugs kill the bacilli in vivo. Bacteriostatic drugs inhibit the multiplication of the bacilli and leads to their destruction by the immune mechanism of the host. We will discussed in detail about bactericidal drugs. Bactericidal drugs include rifampicin, isoniazid, streptomycin, pyroxenamide. Rifampicin. Rifampicin is a powerful bactericidal drug. It is a better sterilizing agent than isoniazid. It permeates all tissue membrane, include the blood-brain and placental barriers. It is equally effective against intracellular as well as extracellular bacilli. It is the only bactericidal active against the persister or dominant bacilli, which are found in the solid causation lesion, solid caseous lesions all over drug being inactive. In this regard, it has a distinct disadvantage over isoniazid. Rifampicin is of special value when the bacillar resistant of other drugs. In combination with the isoniazid, it can cure even extensive tuberculosis in about 9 months. Rifampicin is used only oral drugs. It is also it is of well absorbed that there is little need for parental administration. The dose should be taken at least 1 hour before or 2 hours after food because absorption is reduced by food. It is never used along with the treatment of tuberculosis, but always used in combination with isoniazid or another drugs. Many patients develop nausea at the start of the treatment, but this passes off. The toxic effects include hepatotoxicity, gastritis, influenza like illness, purpura, thrombocytopenia, and nephrotoxicity. The patient should be told that the drugs will turn the urine red. This can be used at least this can be used as just to complain. Pass delay its absorption. Hence, concurrent administration with the pass should be avoided. If rifampicin is stopped for some reason, it should not be restarted within 3 weeks to avoid hypersensitivity. Isoniazid. Isoniazid rank among the most powerful drug in the treatment of TB. It can easily penetrate the cell membrane and thus active against intracellular and extracellular bacilli. Patients may experience GA irritation, peripheral neuropathy, blood dyscrasis, hyperglycemia, and liver damage. Streptomycin. Streptomycin is a bactericidal, one of another bactericidal. It acts as ender of the rapidly multiplying bacilli. It has been shown that when bacilli are multiplying rapidly, then come out of the phagocytes and are mostly extracellular and are therefore susceptible to streptomycin. Streptomycin is less active